Next, I'd like to introduce Dr. Ghassan Wahbeh, who will play the con in regards to the role of nutrition therapy in IBD. Dr. Wahbeh is the director of the Inflammatory Bowel Disease Center at Seattle Children's University. At the hospital, he's an associate professor of pediatrics and gastroenterology at the University of Washington School of Medicine. Dr. Wahbeh's clinical focus is in advanced care for children with Crohn's disease and ulcerative colitis, as well as including advanced therapeutics and pre- and post-surgery of IBD management in these patients. Dr. Wahbeh is actively involved as teaching faculty for medical students, residents, and fellows. He is the honored recipient of the Outstanding Teaching Faculty Award, as well as the Family Choice Award and the Northwest CCFA Service Award. Dr. Wahbeh continues to serve as a member of the National Professional Education Committee of the CCFA, as well as the Northwest Medical Advisory Committee. He's a board member of IBD Horizons. He's a close colleague and friend of mine, so please give him a warm welcome.
Thank you so much for the kind introduction. I'm honored to actually debate Dave, who I've known for almost 14 years. And I have to credit Dr. Susskind with really taking up a very difficult subject, because it's uncomfortable for a lot of providers to talk about diet with patients, and we know that patients want to talk about this. And I want to credit Dr. Susskind with taking that subject, a difficult subject, and actually studying it. A lot of difficulties studying a topic like this, no doubt, a lot of design challenges, but he's one of very, very few who actually look at it scientifically. I really want to credit him with that, so thank you so much. My talk is to convince you that focusing on diet therapies in IBD today is a distraction. These are my disclosures. I'm not going to argue that good, healthy nutrition is essential for a healthy life. It's not on my table today. And I'm not going to argue even that nutrition has a role in IBD. I'm not going to argue that nutrition influences the microbiome. I'm not going to argue that nutrition may have to do with causing IBD at some capacity that we don't fully understand. I'm not going to argue that diet doesn't change the course of IBD. Diet may reduce IBS symptoms that patients confuse with IBD symptoms, and maybe in what we see from small open label and to some degree blinded small-scale studies that the inflammation can be reduced. And I'm not going to even argue that very mild IBD, specifically very mild Crohn's disease, especially in adults, should not be looked at the same way as I would look at a 16-year-old with moderate or severe disease, or if you in adult practice, for those who practice adult IBD, see a patient with moderate or severe disease. Very mild IBD, I think, is a different category that I wouldn't even go there. But here's what I would argue. In its current state, what we propose as nutrition therapy, or try to even look at as proposed nutrition therapy in pediatric and adult IBD, is a distraction from established effective treatments which can achieve very high-reaching and consequential endpoints. And that's what I hope to show you in my talk. The principles I want to argue on are that the goals of treatment in IBD are clear. It's early and effective therapy, and these early effective therapies change outcomes. I hope to convince you that no diet to date has proven a long-term effective record. I hope to convince you that partially successful therapy has a cost. And I will finish by addressing where I would place diet in my practice today. So I'll begin with outlining this. I don't need to spend too much time on this. We all know what remission should look like. Absence of symptoms, restoration of growth in pediatric IBD, normalization of laboratory markers, normalizing the bone density or stopping progressive loss of bone strength in adults, normal psychosocial development, normal productivity, so no interruption from work, ideally without steroids, and last but not least, mucosal healing, because that has been shown to reduce hospitalizations and reduce surgery. So what constitutes early effective therapy today? It's also, this is not ambiguous. We know that biologics with therapeutic drug monitoring, ideally in combination therapy, early initiation of these combination therapies, avoiding steroids and shooting for complete and not partial mucosal healing is what constitutes early effective therapy today. So I'll show you some data to hopefully convince you along the lines that I would argue on. This is a study in pediatrics that looked at the timing of introducing TNF antibodies. And early was defined as less than 3 months from diagnosis or more than 3 months from diagnosis. And the outcome here was the 1-year corticosteroid-free, surgery-free remission. And you see here that if you start the TNF antibody early, within 3 months, at the end of the year, 85% of your patients were in corticosteroid-free remission without surgery. But if you delay, so if you only do immune modulators or you do nothing, neither immune modulator nor biologic, even if you start those later, in many patients, your results are not as good. So you lose a window here if you delay starting the biologics. And focusing on nutritional therapies early on can be exactly what costs us that window. I'm going to use some of the adult data to show you what we have. This is the SONIC trial, and in the SONIC trial, we know, again, I didn't put this slide to show you that combination therapy is better than monotherapy, and this is the data for mucosal healing. But I would point out here that it is actually disappointing when you look at combination therapy at week 26, ending up with 43.9% mucosal healing. This is not a great number, and the reason why I think it's not a great number, and we know this, is because the median disease duration in this trial was 2.3 years. This is a missed opportunity, again, for better results. Let's look at the data with adalimumab, and you see the same trend. This is the overall mucosal healing at week 52 versus placebo, and you see that the rate of mucosal healing is 19%. However, when you break it down by disease duration, there's a big jump when you look at disease that is less than 2 years. And these patients in this trial had disease for about 9 or 10 years. So 2 missed windows here, and even 2 years left you with small numbers in achieving mucosal healing. Now, what happens when you take adults or pediatric patients and you treat them early on with combination therapy? Well, this was done. This is a Dehane study back in 2008, and within 2 weeks of diagnosis, these adult patients were started on the top-down approach, so infliximab induction 0 to 6 weeks and azathioprine, versus a group that was in the step-up arm. And at that time, I think early in the study, there was no continuation of the infliximab, so this is just induction. But at week 104, you can see this. No ulceration. This is not ambiguous mucosal healing, partial or full, or score this or score that. This is absence of any ulcers. And it was 73% for the top-down therapy within 2 weeks of diagnosis versus 30% for the step-up therapy. And a large number of patients in the control group, the step-up therapy, ended up on biologics and immune modulators anyway. So this is what happens when you invest in that window. This study was duplicated in its design in Korea, in pediatrics. And in this trial, patients were randomized to either get early anti-TNF plus immune modulator without steroids, or step-up therapy with steroids, immune modulators, and later alpha-TNF antibody. The clinical remission at the end of 14 and 52 weeks were equal, but the mucosal healing rate, week 14 was 51% for early immune modulator, and look at early, 0.7 months, that's 3 weeks. So 51% mucosal healing, and again, complete mucosal healing. This is endoscopic score for the inflammation of 0. Not 1, 2, not 3, not 4, none of that. 0. No visible ulcers. And at week 52, it was a stunning 74%. And you compare this to the late escalation to TNF-alpha, and late is not a year or 2 or 3 or 4, this was 8 months, and you already lose a good percentage of your patients without mucosal healing. That's a big window that was missed. So what about timing of initiation of TNF antibodies with or without immune modulators and the risk of surgery? This is a study from Spain that retrospectively looked at the risk of delaying initiation of TNF antibodies and immune modulators and the risk of surgery. So for each month delay of introducing anti-TNFs with or without immune modulators, there was a 0.5% risk of surgery. So if you go 1 full year without starting either agent for these adult patients, you had a 6.2% risk of surgery versus none if you started the immune modulator and the biologic plus or minus immune modulator early. So there's a risk of surgery, there's a risk of worse response, worse mucosal healing if you delay. In this conclusion, the authors said that the window of opportunity begins with the diagnosis of Crohn's disease. It's not 2 years, it's not 1 year. It's very well under 3 months, and some may argue that it's actually within 2 to 3 weeks. So let's look at how the dietary intervention as we know it today performs when it comes to these metrics. So I'll start with exclusive enteral nutrition. As Dr. Susskind smartly predicted, I did use the study that he referred to, and I used it to show that there's no question that exclusive enteral nutrition is equal to steroids in achieving clinical remission. However, there's a big difference when it comes to mucosal healing. However, this is what I wanted to point out. When you use steroids versus when you use enteral nutrition, you do have a higher incidence of growth failure if you use steroids. So nutrition therapy reduces growth issues in IBD. There's also the avoidance of steroid dependence, obviously, if you avoid steroids altogether. But even if you go on immune modulators after you induce with steroids or nutrition, your resection rates at 2 years are similar. So much for changing the natural history. A challenge is, what do we do after we start our patients on exclusive enteral nutrition? And again, if you're not familiar with that, Dr. Susskind referred to it in his slide. Patients can do the majority of their caloric requirements by a liquid formula or liquid shake, balanced nutrition, and whether you go 80 or 90% of the total calorie intake, there's a lot of debate on this. And you continue this for anywhere between 6 weeks to 12 weeks, and then it's up in the air where you go from here. If you stop the exclusive enteral nutrition, there's a 60 to 70% chance of recurrence. So I think we all agree that you have to do something for the overwhelming majority, if not all, patients who stop exclusive enteral nutrition. There is no clarity on the role of immune modulators. As you saw, some of the studies moved patients from exclusive enteral nutrition to immune modulators, and in that case, azathioprine. And Dr. Lee outlined clearly what our concerns are about azathioprine. And actually, the developed registry data was published a couple of weeks ago. I didn't have enough time to modify the slide, but the risk of azathioprine is real. There were 5 cases of hemophagocytic histiocytosis, lymphohistiocytosis, and these are severe conditions that have severely worrisome outcomes. And there were certainly multiple cases of lymphoma and leukemia in this registry. And the risk was with azathioprine, not with the biologics. So again, the notion of going on exclusive enteral nutrition, even though it's as good as steroids, and then going on immune modulators, is not a good model. And therefore, I don't see the reason why we should delay the TNF antibody early on. Now, another question that comes up, and some schools of thought follow the notion of treat when the inflammation shows signs of coming back. So, patients go on EEN, they feel great, their laboratory markers are better. Some may go into mucosal healing, and then you stop it after 6 to 12 weeks, and then you wait, look for the inflammation coming back or early signs of the inflammation coming back, whatever you want to follow, calprotectin or CRP, and then you go back on the EEN. So you do this, up and down treatment of the disease, and I would put a lot of money and wine down that when you scope a patient in the trough here, you will find disease. And I have done it for some of my patients who went on this approach to prove a point, and they always have disease. So the up and down therapy without maintenance therapy that is effective is a waste of a patient's time, in my opinion. So let's directly compare exclusive enteral nutrition to TNF antibodies, see what fares better. This is a study led by my wonderful colleague, Dale Lee, no relation to Scott Lee, who compared the outcomes in terms of clinical remission and clinical response when patients went on exclusive enteral nutrition versus anti-TNF therapy. And it wasn't far off in terms of the clinical remission and the clinical response. So nutrition works to improve symptoms for the majority of patients. But if you look at the surrogates of mucosal healing, in all categories, the TNF therapy fared better than the exclusive enteral nutrition. And that's also by a margin. If you look at a cutoff of 250 for stool calprotectin, that's a different debate altogether there. But let's look at that cutoff of 250, 62% versus 45%. And if you look at the stringent cutoff of 50 for the fecal calprotectin, that's 30% versus 5%. And that's over 8 weeks. So a huge difference when you go on a TNF therapy versus exclusive enteral nutrition. Another study that looked at exclusive enteral nutrition and mucosal healing showed us this. Complete mucosal healing. So when you look at the definition of absence of all ulcers on ileocolonoscopy, only occurs in 33% of patients when you go on exclusive enteral nutrition. And in that study where patients went on nutrition then immune modulators, the outcome was only significant if complete mucosal healing was achieved, not near complete mucosal healing. So it makes a difference whether you go all the way with the healing or partially all the way in the partial of the way to heal. So again, remember the benchmark that I pointed out in pediatrics and adults, where you get above 70% complete mucosal healing with absence of any ulceration. So I'll look at the specific carbohydrate diet question. Does the specific carbohydrate diet cause mucosal healing or not? Now, we retrospectively looked at our patients who are on the specific carbohydrate diet, who had endoscopic exam while on the diet, and the diet was the monotherapy, no other medical therapy. We had no patients who were on the strict specific carbohydrate diet. So these data were actually 7 patients that we identified who were on the modified specific carbohydrate diet. What constitutes a modified specific carbohydrate diet? I think that's also a bit of an ambiguous term. But I'll give you the scenario of what we saw. This was a 13-year-old patient with Crohn's disease who started with a specific carbohydrate diet and then eased off some of the restrictions of the diet and was on the modified specific carbohydrate diet. Her CRP was normal, her hemoglobin was normal, sedimentation rate was normal, and her albumin was normal, and she was asymptomatic. Her calprotectin was 195, and again, this is a separate debate as to what do you make of calprotectin levels. We did the endoscopy for the sole purpose of assessing mucosal healing, and these are the ulcers that we saw. It was significant disease. It wasn't mild disease. It was more on the moderate side. Certainly was not severe. When you look at all the patients that we found, and again, when patients feel well, we all know that they're very reluctant to undergo a colonoscopy. I understand where that's coming from. We all probably would not do that either. But in those 7 patients, asymptomatic on their version of the modified specific carbohydrate diet, and their laboratory almost always were normal with minor exceptions. One patient was barely above the cutoff for normal CRP. One was barely below the cutoff for albumin. And their calprotectin levels ranged from 65 to 312 with a median of 201. Again, we did the endoscopy for the sole purpose, the colonoscopy for the sole purpose of assessing mucosal healing, and we assigned the simple endoscopic score for Crohn's disease for those colonoscopies. And we saw that only 1 out of 7 cleared all colonic ulceration. And in the one patient who cleared all the colonic ulcerations, that patient had persistent upper GI tract ulcers. In the process of looking at the patient's data over the follow-up duration, 2 out of 7 developed a non-obstructive mild stricture. Another thing about the specific carbohydrate diet is that the data is not quite clear about how successful is it to make up for the growth challenges that patients with Crohn's disease face. As an example, in one of the studies, while 7 out of 10 patients who felt better on the diet gained weight, 3 actually lost weight. The BMI for several patients dropped from baseline. In a longer-term study where patients on the specific carbohydrate diet were compared to controls who are on standard medical therapy, you can see that the change in BMI went up from 18 to 23 in the controls on medical therapy and had a smaller change from 17 to 18 on the SCD. And this is the 12-month outcome. So I can guarantee you none of these patients were on steroids for 12 months. We don't do that. So the change in the BMI was not attributed to weight gain as a side effect of steroids. So here's what we don't know about the diet. There are no long-term results proving that we can save growth on a modified specific carbohydrate diet or complete specific carbohydrate diet or even long-term exclusive enteral nutrition. We don't know what the mucosal healing rates are long-term. We know it's short-term for exclusive enteral nutrition. For the specific carbohydrate diet, we don't know at all what the rate of mucosal healing is. For the modified specific carbohydrate diet, it does not look to be encouraging. And again, there's a huge gray zone here of what defines a modified specific carbohydrate diet. And we don't know the long-term effect on reducing surgery and hospitalizations with diet therapy. What's inconsistent about the numerous dietary therapies out there is that you get a lot of positive results with any of these therapies. Exclusive enteral nutrition, 80 or 90% enteral nutrition, 50% enteral nutrition, standard formula, low glutamine, glutamine enriched, amino acid based, tissue growth factor enriched, high sugar, which is the exclusive enteral nutrition in some form, low sugar, which is the SCD, low calories if you do some gut rest, and that's maybe just reducing symptoms, not inflammation, or high calories if you just put a nasogastric tube and add more calories. Whether you take it by mouth or you take it by tube, doesn't matter. If you go vegetarian or semi-vegetarian, it helps as well. So there's a lot of inconsistencies about what we can do to reduce patients' symptoms and maybe improve their labs with all these varieties of the diet. The SCD seems to be the most accepted because of the fact that it's more real food than a lot of the formula-based therapies. There's also a bias to positive results in early onset IBD. And you can argue that's probably maybe the same reason that biologics can fare better early on in the disease. I wouldn't put an argument against that. But a lot of them are short-term studies, not long-term studies. Off of the diet, there's a high recurrence rate of the inflammation. And we have to wonder if it's actually the change itself. It's just a matter of changing the diet to something else that makes things better. Or maybe the diet itself that our patients are on is adding to the inflammation. So changing the diet takes that additional burden, but doesn't treat the actual IBD disease burden. And I'll put this up. This is a manuscript in progress, again, by my wonderful colleague, Dr. Lee, no relation to Scott Lee, who did this incredible study where over the course of, I don't know how many weeks, the researchers went to Safeway, analyzed pretty much all the foods that the patients recorded on a diary that they were eating, and looked at which foods contained what in terms of additives, preservatives, and emulsifiers, yada, yada, yada. And here are the results. If you buy a frozen treat, frozen dessert, 66% of those had carrageenan, which is an emulsifier. Soy lecithin, 50%. Xanthan gum, 45%. If you buy a prepared meal or one of those sauces that you can use with meat, poultry, or fish, again, the majority had additives, including emulsifiers. Even grains and breads had emulsifiers. This is the bread that has 13 ingredients instead of 4 ingredients. When you look at soy lecithin, which is an emulsifier, and Dr. Susskind showed what emulsifiers can do in mouse models, 90% of cookies for heaven's sake, 91% of them had soy lecithin. Meal replacement beverages, 59% of them had soy lecithin. Pasta, rice, and grain recipes, 40% had soy lecithin. So these patients are exposed to a mean of 5 food items every day that had some preservative or additive, and they were exposed on average to almost 3 different additives on any given day. So this is what your patients are eating when you're not asking. So I'll finish with a couple of slides here. One is comparing what we know about early combination therapy, and early means within a couple of weeks, versus nutritional therapy. Do symptoms get better on both? Yes. Do the laboratory markers get better on both? I'm going to concede and say yes. Is there long-term growth with early combination therapy? Yes. With EEN, maybe short-term and to some degree medium-term, but not on the specific carbohydrate diet. Long-term mucosal healing, yes, for the early combination therapy. Very short-term for the exclusive enteral nutrition, and it's way less. less surgery, we don't know what happens with nutritional therapies, less hospitalizations, we don't know. When it comes to the risk and benefit balance, again, this is not the scope of my talk. I think undertreating disease is not a justification for a safer approach. Diet therapy is safer than combination therapy, but diet therapy may not perform as well. So in conclusion, effective therapies with long-term steroid-free remission and complete mucosal healing exist. We know what these effective therapies are. There is no comparable options to date that comes in any diet form. The window of optimal results for treating with combination therapy is very short, that's weeks. And then partial therapy success, if patients feel better but they're not achieving the full goals of remission, that's not without a cost. But I would also say that nutritional therapy should be always in our mind and be used instead of steroids, maybe help correct some growth failure. Everybody should eat a healthier diet that has, wholesome, unpackaged, and low refined sugar-based diet. And there may be some future role in diet therapy on its own, maybe in de-escalation in the future or not. I think there are a lot of research venues, and I want to again credit Dr. Susskind for pushing the bar on that. But the one thing I would say is that knowing what we know today, we should not let the nutritional therapies be a distraction and delay us from starting effective combination therapy. Thank you.